Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Mariposa Community Health Center for hosting today's session, ECG Mini-Series number 2, Ischemia and Other ST and T-Wave Abnormalities with Dr. Charles Schulman. Dr. Schulman is a senior physician emeritus who recently retired from active practice after 53 years, but continues to teach and consulting. In addition, he has been practicing non-invasive cardiology since 1970, and we are just so very lucky to have him as one of our MAVEN Project volunteers. So Dr. Schulman, when you're ready.
Thank you very much, Kristen, and good, good morning. Yes, it's morning there. So, yes, good morning, everybody. This is the second of our 3-session series on ECGs. And so today we'll talk about the ST segment and the T wave of the electrocardiogram. I have no disclosures, nor does anybody else that has anything to do with this project. And it is designated for an hour of Category 1 credit. The learning objectives are to recognize deviations of the ST segment and the T wave, to understand when ST segment and T wave changes represent ischemia and when they do not, to recognize prolonged QTC and its risk, and to know etiologies of ST depression. So here's our electrocardiogram in a cartoon form. The P, QRS. This is the J point is at the end of the QRS and beginning of the ST segment. This is the ST segment right here, the T wave, followed by possibly a U wave. That's not terribly common. And then back to baseline. And the ST segment corresponds with phase 2 of the action potential. So it is a recovery or repolarization portion of the depolarization process. The QT interval goes from the beginning of the QRS to the end of the T wave, as noted here. So there are a number of different ST and T wave changes that we'll talk about. ST elevations, as for example, infarction, early repolarization, and pericarditis, ST depression, ischemia, LVH, hypokalemia, T wave changes, inverted and peaked. And okay, so starting off with ST elevations, we're interested in the diagnosis of ST elevation myocardial infarction, called STEMI. Generally, this represents an occlusive myocardial infarction, and a myocardial infarction due to occlusive coronary artery disease or occlusion in one particular vessel. And so the changes are that where there is damage, the initial change is that the T wave vector travels toward the electrode of the involved artery. We'll talk about which ones in a while, giving you an elevated T wave, a so-called hyperacute T wave, followed by an ST elevation, where the ST vector travels toward the electrode. This was previously thought to be transmural as opposed to subendocardial. That's not so accurate anymore. But the ECG changes remain the same. Characteristics of ST elevation caused by ischemia are complex, or straight upsloping, or straight horizontal, whereas non-ischemic ST elevation would be concave, frowny face versus smiley face. So here's a 68-year-old man who presented to the emergency room with chest pain. And you will notice, well, one thing you notice that there's sinus rhythm. There are three PVCs. There's one PAC. And if you look here in leads V2, 3, and 4, especially V5 also actually, the T waves are very tall, way out of proportion to the size of the QRS. So this is a hyperacute T wave. And it was followed 45 minutes later by ST elevations from V2 through V5, and actually V2 through V6, and also one in AVL. So this is typical of an ST elevation MI. This person should go directly to the cath lab in order to have a stent placed. Now, the changes, the evolution of the ECG and STEMI, I've already alluded to, so that the first change is a hyperacute T wave, followed by ST elevation, followed by the development of Q wave, and the ST segment comes down, T wave inverts, then T wave may recover, and you're left with a Q wave in that particular lead. This is what happened. This is from the olden days. That is prior to revascularization and revascularization and reperfusion. Today, however, many, hopefully most, hopefully almost all of these patients go directly to the cath lab and are revascularized. In which case, with reperfusion, you don't get these ST elevation and changes with the development of Q waves. What you get is inverted T waves. So that's a so-called reperfusion change. And this shows the different anatomic locations and the supplying coronary arteries. So leads 2, 3, and AVF are inferior, mostly the right coronary, but sometimes the left circumflex. Leads 1 and 2 are called septal, and V1 through V4 are called they're all called anterior rather. Septal MIs actually don't produce echo changes that aren't exactly where the EKG looks like they would be. They're further south. they're further distal. Leads 1 AVL and V5, V6 are lateral. So a circumflex or a diagonal branch will cause changes in those leads. And then you can have some combinations. You can have inferolateral or anterolateral changes. Okay. So here is a 71-year-old man who complained of shortness of breath and almost passed out. And what you see is a very slow rate. His heart rate is 300, 150, 100, 75, 60, 50, 43. So his heart rate is 43. And you notice that the P waves and QRSs have no relation to each other. They march right through. Okay, so he has complete heart block. The reason he has complete heart block is because he has ST elevation in leads 2, 3, and AVF. 3 is greater than 2. All right, two is not quite so prominent. This is confusing because there's a P wave stuck in there. See here it shows it a little bit better. And in inferior infarctions, if the ST elevation is greater in lead 3 than it is in lead 2, that's almost certainly the right coronary artery. Okay, so the right coronary artery has caused this STEMI and heart block. A stent was placed in his mid coronary artery, treating a right coronary occlusion, and he now has sinus rhythm. You notice, okay. So what is the relationship of right coronary occlusion to an acute inferior STEMI? Somebody want to answer that in the chat?
You can type right into the chat box.
Okay. No takers?
No takers.
No takers. The answer is, if I can advance the slide, the answer is that the blood supply to the AV node in 90% of patients comes from the right coronary artery. So an occlusion here causes ischemia to the AV node. The result is that you can have heart block in the region of the AV node, this is usually temporary. It doesn't usually require a pacemaker, and it usually recovers. Okay. Here is what's called infero-posterior MI. So highlighted here are ST elevations in leads 2, 3, and AVF. And you notice these very deep ST depressions in V1 through V3. If you put that up to a mirror, however, you reverse leads V1, 2, 3 like that, it looks like ST elevation. And that's because, and this is the posterior area located here. And so you see the vector goes toward the back. If we were to take V7, V8, V9, we'd see ST elevations. But in V1, 2, 3, we see ST depressions because the vector is traveling away from V1, 2, 3. Now, ST elevations are not always acute myocardial infarction. This mnemonic lists, a large number of them. We'll look at some of them, including electrolytes, left bundle branch block, early repolarization, ventricular hypertrophy, some arrhythmias, but also infarction and vasospasm. So here is left bundle branch block, and you'll notice that there is ST elevation in leads V1 through V3, actually. Now, these are secondary STT changes. In bundle branch block, and there will be ST and T wave changes in a direction opposite the major QRS abnormality. So in right bundle, where the major abnormality is positive, right, the RSR prime, right, ST segment is depressed, T wave inverted. In typical left bundle, the major deflection is, a large S wave. It's negative, therefore ST and T wave are upright, as shown here. The same would be true for left ventricular hypertrophy, as noted here. So those are secondary changes. Those are not primary changes. And they, of course, are part of the underlying process rather than a new process like ischemia. Here's a 67-year-old woman who complained of chest pain at rest. This is an unusual situation that was given to me by Elio Fine, who ran the EKG lab at Beth Israel for 40 years or 40 plus years. You notice the date on here. It's not very common. Okay. Notice the date and notice the time. All right. And what does it show? Well, it shows these nasty looking ST elevations in 2, 3, V2, V4, 5, 6, and ST depressions in, 1L and V1 and V2. Is this a STEMI? Well, somebody gave this woman nitroglycerin. The treating doctor gave her a nitroglycerin. And this is what happened. Notice the time. This is 6 minutes later. The ST elevations are gone. And this is a syndrome called this is coronary vasospasm or Prinzmetal angina, and this is a monitor tracing of spasm that's occurring. And you see the ST segments going up, and then these nasty looking ventricular arrhythmias. This is coronary vasospasm on a rather diffuse coronary vasospasm on a coronary angiogram before and after nitroglycerin, showing relief with nitroglycerin. Now here is a 36-year-old man who has hypertension, hyperlipidemia, who had 3 days of chest pain, which was worse on lying down. He has ST elevations in leads 1, 2, not so much in 3, a little bit in F, a little bit in L, V2, V3, okay? Sort of diffuse ST elevations don't really follow one of the coronary vessels. He also has PR depression in lead 2 and PR elevation in lead AVR. This is pericarditis. Okay. The ST elevations are not so well shown here, but often concave up, along with the PR depression. Okay. Here is a here is the ECG of a young 47-year-old, right? Remember, to me, everybody is young. A woman who complained to one of the nurse practitioners in our clinic of a sharp pinching chest pain. But the EKG, the computer said, consider acute ST elevation MI. That's what it says. Okay, and there are indeed ST elevations in leads 1, 2, 3, F, V4, V5, V6. Is this a STEMI? Should we send her to the hospital? The answer is no, we shouldn't. This is the early repolarization abnormality. An elevation of the J point, and this so-called J wave, this is what I call a dipsy doodle. Okay. That's very different from the ST elevation of a STEMI. Okay, there's another picture of it. Remember, this is the smiley face, not a frowny face. And this is what happens if you exercise somebody with this abnormality. It improves. See, got better. So if you have such a problem in your such a patient in your clinic, what you might do is ask them to exercise, do jumping jacks, or in order to try to raise their heart rate and see if you can't get the same result. Now, here's an EKG with some very tall T waves. The question is, are these hyperacute T waves of an early ST elevation MI, or is this hyperkalemia? Put your answer in the chat. Hyperacute Ts or hyperkalemia? No
Right.
takers?
Quiet
Oh,
group today.
yeah, yeah. Well, okay. No, no takers. All right. Well, you notice how these are certainly tall T waves and certainly raise the question of hyperkalemia, don't they? But there's a difference. And this is the difference. The T waves of hyperkalemia are very pointy, like that. Prick your finger. Whereas the ST elevations, the tall T waves of hyperacute ischemia are symmetric, broad-based, and not pointed. And the QT interval tends to be long. So here's a woman in her 40s who was found down, brought to the emergency room, and this is her electrocardiogram. What do you think of these T waves? Hmm? Huh? Yes, yes. This is hyperkalemia. Yes, you all got it right. This is hyperkalemia, all right. Uh, what? Wait a minute. Ah, her K was 8.1. This is she was given calcium gluconate, insulin, and bicarbonate, and her K is now 6.5. They're much better, but they're still a little pointy. Okay, this is severe hyperkalemia. Again, tall, pointy T waves, but wide QRS, ST abnormalities. You can't really see P waves, but wide, bizarre QRS. So just, so you recognize this. Okay, now here is a 54-year-old woman with hypertension and alcohol abuse who presented with 3 episodes of syncope in 24 hours. What's going on here? Well, here's a ventricular couplet. She's got sinus rhythm. What do you notice about this? What you notice is that her QT is long. Look how long her QT interval is from there to there. Okay. Normal QT is less than half of the RR. Long QT is more than half of the RR. And what do you think the arrhythmia was? Polymorphic VT or torsade de pointe, right? Torsion of the points. Ventricular tachycardia where the points go from up to down to up again in the same lead. So that's the risk. That's the risk with prolonged QT. And these are some risk factors for drug-induced torsade, which is really why I bring this up, because there are a number of drugs, and I'll show you that on the next slide, which can prolong the QT. So if you have the risk factors for drug-induced torsade are prolonged QT, that's QTC that's more than 500 milliseconds, the use of QT prolonging drugs, especially if there's more than one of them. The three hypos, hypokalemia, hypomagnesemia, hypocalcemia, the use of diuretics because it causes hypocalcemia, heart disease, heart failure, MIs, again, because of QT issues, and bradycardia from any cause. The QT interval is inversely proportional to the heart rate. The faster the heart rate, the shorter the QT. The slower the heart rate, the longer the QTs. So if you have torsade with a long QT, increasing the heart rate will help. These are some of the drugs. It's the full list of drugs about a page and a half long, single spaced. But these are some common drugs that pose a risk of torsade. Antiarrhythmic drugs. The ones that I emphasize though are antibiotics, levofloxacin, azithromycin, a commonly used drug, ciprofloxacin, commonly used drug, antidepressants or antipsychotics like amitriptyline, and then other drugs, tyrosine kinase inhibitors, which are cancer drugs, methadone, cyclobenzaprine, because it's similar to amitriptyline. You might, if you're using this as a muscle relaxant, you might want to think about using a different one. Hydroxychloroquine, which we used to talk about in the COVID pandemic, which we don't really talk about much anymore, and ondansetron. And there are a number of clinical scenarios for torsade risk. Concomitant therapy with 2 QT prolonging drugs, concomitant therapy with a diuretic, drugs that influence the metabolism, the QT prolonging drugs, the development of renal failure, development of liver failure. Now, let's turn to ST depression. The common causes of ST segment depression are ischemia, so-called strain, we'll show you that, digitalis effect, hypokalemia and hypomagnesemia, rate-related changes, or some combination thereof. So with ST depressions, the vector is pointing away from the electrode. Say again, this shows seboendocardial ischemia, but it's the ST is pointing away from the electrode, as is the T wave. Now, one cause of ST depressions is reciprocal ST changes in STEMI. So where you have ST elevation The opposite leads will have ST depression. So here, for example, is ST elevation in leads 1 and AVL, and ST depression in 2, 3, and AVF. Here you have ST elevation in leads 2, 3, and AVF, and ST depression in 1 and AVL. Those are the ST depressions in these cases is called reciprocal changes. Sometimes the reciprocal changes are more prominent than the primary changes, so be on the lookout for that. Now, some myocardial infarctions are what's called non-ST elevation MI, and they're associated with ST depressions, as noted here, sometimes with T-wave inversion. Here's a patient that was admitted to our cardiology floor not too long ago, a 77-year-old man with hypertension who underwent carotid endarterectomy. In the recovery room, he had a hypertensive crisis and developed chest pain. And this was his ECG. You notice these rather prominent ST depressions in leads 2, 3, and AVF, and V5 and V6. Okay, and here's his pre-op. You know, those aren't there at all. See that? So these are new changes. His troponin rose. His coronary angiogram showed non-obstructive coronary disease, and the EKG went back to where it was before. So this would be an N-STEMI, an N-STEMI. You see, incidentally, he's got ST depressions in 2, 3, and AVF related to his hypertension. So his very tall R-wave voltage. He's got left ventricular hypertrophy on his tracing. But this is different. You notice that it changed when he had chest pain. Okay, here's a 66-year-old woman with hypertension and diabetes who complained of chest pain. Now, she's got really widespread ST depressions. 1, more in 2, 3, F, V4, 3 through V6. But she's also got a telltale sign of ST elevation in lead AVR. Okay, ST elevation in lead AVR. Beware ST elevation in AVR. ST elevation in AVR with coexistent multi-lead ST depression indicates subendocardial ischemia due to an oxygen supply-demand mismatch, often due to what we commonly associate this with is left main coronary artery severe stenosis. Not necessarily occlusion, because people who have an occlusion of their left main don't often make it to the hospital. But severe stenosis or severe proximal LAD stenosis, severe 3-vessel disease, possibly other causes as well. So it's not specific for left main disease, but you should think left main disease if you see it with acute chest pain. ST elevation in lead AVR is a useful predictor of poor outcome and of the need for CABG. Well, you know, both severe multi-vessel disease and severe stenosis of the left main might require urgent CABG surgery, therefore withhold clopidogrel, and the absence of ST elevation in lead AVR essentially excludes severe left main stenosis. Now, turning to another cause of ST depressions, we'll look at the ST changes during a stress test. Okay, so ST changes during the stress test. So this would be normal. This is really equivalent. This is probably normal, rapid upslope and minor ST depression that, if these disappear within a minute, these are probably non-significant. Shouldn't be called positive. A positive stress test would be ST depression of at least a millimeter, 80 milliseconds after the J point. This is slightly upsloping, this is horizontal, this is downsloping. These are positive tests. Okay. Here's hypokalemia, right? We looked at hyperkalemia. This is hypokalemia. And you get these diffuse ST depressions, T wave inversions. Well, it's hard to tell. And prolonged QT, which becomes more progressive as the potassium is lower and lower. And it goes from here to here to here to here. Okay, and this is hypokalemia with a prolonged QT, and the QT goes all the way over to here. Well, here it goes over. Hard to tell exactly where it ends. Probably over here somewhere. Okay, so this would represent a risk for torsade if the QT is that long. All right, here is a 65-year-old man who has atrial fibrillation, for which he was given digoxin in order to slow his heart rate. He still has atrial fibrillation. He doesn't have any P waves. He has a slow heart rate. Let's see, 300, 150, 100, 75, 60. It's, I don't know, 55-ish. Oh, 51. Okay. Okay. And it's perfectly regular. You notice that? It's perfectly regular. And that's not, in this case, it's not from a beta blocker. A beta blocker can do this, but not, when digoxin does it, it's digitoxic. And these ST depressions, these scoopy looking ST depressions, I described the pill of digitalis sitting right there, but it's also been similar to Salvador Dali's mustache. And here is Vincent van Gogh. Vincent van Gogh had a yellow vision, we think. Look how yellow his face looks. Look how yellow everything looks. And he's holding a foxglove plant. This is a foxglove plant. Foxglove is the plant from which digitalis and digoxin are made. In those days, apparently, they used digitalis as a treatment for depression. It apparently wasn't very successful in Vincent because he cut off his ear, but it made his vision yellow, very yellow, as you can see here. So we have, do I have, no, I don't. Okay. I had one other thing I wanted to show you. Give me a moment and I'll see if I can find it. Um, do this. Let's do this. No, do this. This. Okay. Okay. Um, all right. Okay, can you see this?
Yes.
Okay, thank you. Okay, so this is the last condition I wanted to show you. I wasn't sure we were going to have time for it, so I took it out of the slide deck, but I'm putting it back in. A 72-year-old woman who has had paroxysmal AFib received a pacemaker because she had symptomatic conversion pauses. Okay, so the AF would go along, and all of a sudden would stop and it wouldn't pick up again for a long time. Okay, so she got a pacemaker. Here she is with a pacemaker. These are paced beats, right? And the pacemaker tip is in the right ventricle because the paced beats look like they have a left bundle. If you pace the if you pace the right ventricle, you will have a left bundle branch block. If you pace the left ventricle, you will have a right bundle branch block. So here she is with their standard RV pacer. Okay. A week after the pacemaker implantation, they turned the pacemaker off to see if it was, if it was needed. And you see she has sinus rhythm with occasionally long pauses. Okay. But she also has T-wave inversions in 2, 3, and AVF, and V4, V3, 4, 5, and 6. Is this ischemia? The short answer to the question is no, it's not. It's a condition called cardiac memory. Okay, the right ventricle apparently remembers and has T-wave inversions. So here is another patient, a different patient, with these same T-wave inversions in 2, 3, and AVF and V3 through V6. And here is a patient who has hypertension and unstable angina, who has T-wave inversions in 1 and probably L and V2 through V6. But the difference is, there are a couple of differences. One is that these T waves are broad and the QT is prolonged and it's not in T-wave memory. The other thing is that the T wave is normally upright in AVL in patients with cardiac memory and not in patients with ischemia. So those are two ways of differentiating between the two. And the point is that you need to differentiate between the two so you don't do unnecessary testing and unnecessary potential treatments. Okay. And so, oh, yes. Here's my parting shot, folks. Thank you very much. I'll be glad to take questions.
Thanks, Dr. Schulman. You got a laughing, crying emoji in your in the chat. We have a thank you, Dr. Schulman, in the chat. So just a reminder, if you have any questions, use the Q&A box, the chat box, raise hand feature, and I can unmute you so you can speak to Dr. Schulman. I know words today. And while we're waiting for questions, just a reminder, when you complete the CME survey, that today is August 13th. It gets stuck a lot on some people, and it puts the last time you completed the survey's date and then you don't get your certificate immediately. Lots of thank yous in the chat. And
No.
also, if anybody on this call is planning to attend the NAC conference in Atlanta at the end of the month, let me know. We'll be there and we'd love to actually meet you in person. Not behind a computer screen.
Okay, I can give you, this doesn't have my email. I'll be glad to give you my email if you have questions that you want to ask.
They can, or they can submit an e-consult to you.
Yes, indeedy. If you send an e-consult to Maven, make sure you direct it to me. You have some ECG you want me to look at or something. Direct it to me when you put it in to Maven, and I'll be glad to answer it.
You can select the volunteer instead of going to first available. Just select Dr. Charles Schulman. All right, well, I guess we are out of questions. No questions today. So if you think of them afterwards. Oh, do we have notes on presentations for how to review? So you will get the
slides
tomorrow in an email from Zoom. So you can you'll get it in about 24 hours from now. So you can review the slide deck. And the recording will be up on the community portal within 2 weeks. So if you want to watch this again, please feel free. Yeah. All right. So no questions. Thank you so much, Dr. Schulman. Jen, will see you tomorrow.
Thank you, everybody.
Have a good day.
Take care.